Very good evening, everybody. I'm Dr. Kaumudi, and I'm very privileged here to inaugurate this session on the He for She campaign. And for today, we have two expert panelists, Dr. Bansi sir and Dr. Archana Sarda ma'am. And the topic of discussion for today is type 1 diabetes in women. I hand over to Dhruvi ma'am to take it forward from here.
Thank you so much, Kaumudi. Good evening to everybody who's joined us today virtually, and I'm very, very thankful to our panelists, Dr. Archana Sarda ma'am, who is leading the campaign for type 1 diabetes and its awareness and advocacy from the city of Aurangabad through her UDAN network, which is one of the largest network for advocacy for type 1 diabetes. And our second panelist today, Dr. Banshi Sabu sir, who is an international and a national advocate for type 1 diabetes from the city of Ahmedabad, and all of our teacher. So with that, my first question today, we've, ma'am and sir, we've named this session as Empower Her with type 1 diabetes. So my first question to ma'am is, Archana ma'am, do you think there is some sort of a difference when it comes to type 1 diabetes prevalence between girls and boys? I'll say girls and boys and not males and females.
I don't think so, because whatever we are seeing, the numbers from everywhere, including incidence, prevalence, even in our own numbers, they're pretty much equal.
Thank you, ma'am. There are quite some countries, be it underdeveloped countries, developing countries, and in terms of resources, there are quite some disparities that we are seeing. And I would request Banshi sir to, throw some light onto this factor. So do you think that there is some discrepancy in access to the resources when it comes to resources that are allocated to girls and boys?
So, Durvi, first of all, congratulations for this wonderful program and your series of program which you have. The idea of which you want to do is an empowering woman. That's what a great idea. As far as type 1 is concerned and disparities is concerned, disparities in terms of not I will talk about the male and female disparities in managing type 1 across the country are many, or even across the world. It may be access to the care, it may be access to the insulin therapy, and biggest problem is like today, if I talk for India, access to the technology care. You know, that even suppose somebody is affording, but he is not going at the right doctor, a doctor is not going to give him any knowledge about the newer technology, patient will not be put on a pump, patient will not be on any therapy. Now, as far as you are talking about there is a disparities between male and female child. Now, again, it depends that because those patients who are reaching me or to the Archana is taking care through UDAN, a big NGO which she is taking care of 1,700 children, and she is almost equal number of patients which are type 1, male or female. The same thing may be here with me also in Diacare Trust. But the problem is those patients who are not reaching to us, we don't know whether there is a problem. Because those patients who are reaching to us, we are educating them, we are talking to them that yes, both are equal, we should take care of both these children in an equal way. They may have some psychological issues and we may try to give them a psychological support also. But for those patients who are not reaching or who are not reaching to us or to the expert doctor, they may be going to some primary healthcare center and then they are not getting enough treatment or they are getting problems, recurrent diabetes. Then the female child, there they may suffer more, particularly more from a rural background. And this I have seen when I was a medical student, because at the time I was working in a public health house. Now today I am in a private hospital. I am not seeing this type of disparity, but I believe that this is there in our country. So this is the reason I feel that yes, there may be, but doing more, education program, empowering female. Here I want more education for the caregiver. Female is the, otherwise for type 2 diabetes, when we are talking, we want to educate that female of the family, whether she is not the person who is suffering from disease, whether her parents or her husband or her children, any one of them may be having diabetes, but we want to educate and empower that lady, because if we can take care of her, she can prevent diabetes. Those who does not have in the family, maybe type 2 diabetes, And if anyone in the type 1 diabetes or any other problem in the family, she may take care of all of them. So I feel that's but it is again in a private setup, in a public sector, it may be different, and there are disparities which we know.
May
Not
I
just for
add? May I
everything.
just add a line?
Yes,
Yes.
yes,
Yes,
ma'am.
please.
So while I said the prevalence incidence seems to be similar, I agree with Dr. Banshi, maybe because we don't know the real scenario at the ground level. But when we talk about disparity in access to care, that I see even now, definitely between a girl child and a boy child, there
Yes,
is a difference in the motivation level of parents of willing to take a day off. Suppose a laborer taking a day off, traveling to the hospital, taking treatment, or if needs, suppose they need a supplement, they need something to be able to spend for the child. Definitely there is a disparity on the kind of attention that is given and the kind of, even with low resources and even in high resources. I mean, this disparity of gender is definitely seen. Even now, I see that.
That's the most interesting point of view that Banshi sir and Archana have pointed out right now. I'm going to, channelize my question again to Banshi sir because he brought it up and he started it. Sir, if you have to counsel the parents of a girl with type 1 diabetes, quickly, if you can tell our audience, what would be some things extra that you would like to tell our doctors or teach our doctors listening to you today? What should we be doing additionally to
one
the
thing is counseling, whether you are type 1 male child or a type 1 female child. The mother is to be counseled maximum. So I always see that mother is coming with the parent. I mean, mother is coming with the child, whether it's a female or male. That's the one common thing which we always try to educate this mother of a child. That's the most important thing up to the age of teenagers. But then when it comes to female child, the mother or family have many more issues in their mind. Who will marry? How they will she survive? Will she get the pregnancy if they already in adolescent age? And multiple things, in their mind goes on. The second thing is sometimes disparities if we are talking of the some extraordinary treatment, like we are talking about the pump therapy, we are talking of the patients about continuous glucose monitoring, all those things where they may have some challenges for a female child, but this is now we are seeing less and less. Something very specific education point of view, definitely for teenage girls, I talk to them because during their mens and they are also having more psychological issues. The sugar level may fluctuate more in compared to the male. So this happen more with the female children in compared to male, but that happens more when they are in adolescence or in the teenage during their mens, or they have some other psychological issues which they may have. The other thing is thyroid and other autoimmune disease are also common with these female children. So we have to screen them more frequently.
So I
Thank
can
you so
just add
much.
one thing to
Yes,
it.
ma'am.
What extra, other than everything that Dr. Banshi has said, counseling parents of a girl with type 1 diabetes, my focus always remains in telling them that she has to become financially independent because of the social structure of what is going to happen. And that's not a thought which always comes naturally to parents because traditionally still financial independence is not seen as a priority. Many of them are so loving and caring, so-called loving and caring, that they say, we will take care of her all our life, don't worry. So that is not an encouraging thing for a girl to know that somebody is going to take care of them all their life and is willing to keep them as a dependent all their life. That is not something they want to know. What they want to know is that they can live a fulfilling life. So that's one part which we insist and add to all the rest of the counseling for a girl child.
Very, very good.
So amazing. Again, out of curiosity, ma'am and sir, I've always thought that there are kids who drop out of school because of type 1 diabetes. Now, in both of yours experiences, have you observed that it is the girl child who drops out more often, or is it, the male child who drops out more often, or is it no?
It is boys. They are
Boys?
not here and they use it as a pretext
Okay.
because they use it as a lever to, sort of blackmail their parents and all that. Girls actually want to do that because I think by nature they're more disciplined. So no such disparity of dropping out of school. Parents, most of the schools are free also in the government setup if you see low resource settings. And unless they're bullied or scared and the environment in the school is not okay, which could be same for both boys and girls. So we have not seen a difference. If any, more boys drop out.
Sir, any comments on the question?
No, I think what Archana is saying very true. And I mean, both the children equally have there won't be any disparity as far as that school. The
Okay,
only
sir.
concern is school-going children, particularly for female, because the privacy issue is more with them.
Mhm.
Some of the public schools, they may not have that, giving them a privacy where they can inject insulin safely. That's a problem with children. So we normally write a letter to the school teacher that she is having type 1 diabetes and she may require a place safely where she can inject the injection.
Sir, I'll direct my next question to you. And moving from childhood to adolescence and through the pubertal time, how is menstruation impacting these girls with type 1 diabetes and their adherence towards the insulin doses? And how is it impacting their regular life as well, sir?
So one is there is a lot of fluctuation, which we explain also in advance sometime, but it is really very difficult. The problem is for a type 1 child to check their sugar multiple times and inject insulin accordingly and doing a carb counting, doing a insulin carb ratio properly, checking their sugar more frequently is sometimes really a challenge. The LFSC is helping us to provide glucose meter and strips, and we are providing almost more than 400 children, more than 100 strips per month, and along with them a glucose meter. But still, sometimes the parents have also a problem that they don't want to get that checked again and again. They always feel that, sir, it keeps on changing, and why you want my child to prick her for 6 times, 7 times, or 5 times? That's really a challenge. And this challenge increases much more when a child is in the menstruation or in menarche stage where the glucose fluctuation is much more high. During adolescence also, we have seen that suddenly their insulin requirement increases so much. So we have to simultaneously increase the basal dose. Sometimes, the doctors talk about only the correction dose and then patient ultimately ends up with very high amount of bolus dose and the basal is not increased. So, I mean, bolus is also, along with bolus, we have to simultaneously increase the basal. If you are saying that continuously that pre-meals and fasting is increasing, you please increase the basal dose and then you have to maintain. I mean, then you just keep on correction dose, go on giving. So I see the patients after 15 days, 30 days, and see that how many times the patient have taken extra correction dose. And accordingly, you have to increase both the doses of basal and bolus. But that happens more during menarche time and during menstrual phase.
Thank you.
So I'll add to
Archana, ma'am,
that.
I'll get to you. Yeah.
Okay,
Yes, ma'am.
I just thought I'll add to the same thing
Yeah.
that as Dr. Bansi just said, in addition, we usually see hyperglycemia more in the luteal phase. So people are prepared that that is the time that is likely to be hyperglycemic. Still, it varies. There are girls who would not have hyperglycemia in that phase, but usually because of lower insulin sensitivity, that is the time. But what we do as a trick to do it in the diary, we ask the girls to put red dots on the days that they are in menses. So when they are actually menstruating and the first day of their menses till it lasts, if they just make a red pen mark in their logbook, so over months they realize a pattern that when do they get hyperglycemic. And usually most girls, they would be different. All of them would not have the same phase, but for an individual, the pattern is similar.
Okay.
So
Thank you, ma'am.
next
That
time,
was going
as
to be
Dr.
my second
Bansi
question
said,
to you. Yeah.
sorry.
How do you adjust that dose? A lot of us do not understand and menses वाले दिन कैसा करना है, pre-menstrual वाले दिन पे कैसा करना है, at the ovulation day, how do you adjust it? Do you have a number or is there some very easy
There's
thing
no
to
number. The
No.
easiest way is first 2-3 months, let them observe because all of them are trained to adjust their dose the way Dr. Banshi said from the bolus point of view, right? As a correction bolus. But that is a short-term answer. But once you do it for 2-3 months, you also see your patterns by seeing your logbook and marking your days, whether it's a digital log or a paper log. And that very clearly tells you how your body behaves. And it is different for different girls, not always the same. And that helps us, they preempt that now I am, the XYZ date is of my periods. I usually am high 7 days before, and that is the time they increase their bolus. So that the basal, they increase their basal rate as well, so that less adjustments with the bolus happens. And they also know the time of the day, which is, so they are able to do that. But observation is important because there's no one thumb rule which works for all of them.
Thank you, ma'am. That was really interesting for all of us to understand, because girls come in with a varied, logbook with a lot of numbers that sometimes you feel may be fabricated, or are they really checking it or not, or why is such a wide variation visible on their logbook. The other thing that these adolescent girls go through is their body image issues. And, I think quite some of us would have seen that there are some girls who know how to tweak their insulin to remain thin. They would keep their bodies into a constant state of hyperglycemia because they don't want to put on weight. And then there are girls who have some mental issues with the idea that they have to constantly take insulin or make so many decisions. How do we cater to that phase of rebelliousness, maybe?
Okay, so I think that adolescent phase is tough, irrespective of diabetes. So that is a tough phase. So there are two very opposite things which are needed at the same time. One, we have to be absolutely non-judgmental when we talk to these girls, because the moment there is a hint of judgment, they will just shut up and they will not share things. Then you can just do anything and you will never come to know the truth. So at the same time, we have to find a way to steer them towards whatever is right. So these are exactly two opposite things. What really works for us in a counseling service is during the phase, adolescent phase, we are just their friends. We try not to be too good, because the moment we try to be preachy or try to do what's right, then we are no longer their friends. So we had to choose between having a very tight control versus having a girl telling honestly what she's doing with herself. So we have lots of red flags marked in our minds, in our team, and we know that what are those red flags. And for those red flags, as you said, if somebody is keeping herself hyperglycemic, or taking missing insulin at times. So those things are definitely have to brought back in. And then empathy for the body image. If you tell them, no, you don't have to be size 0, they're not going to listen to you, because that's her priority, right? So we have to, while not pushing it, but we cannot, undermine their desire. And third thing which really works is peer group. So we always have a few young girls of the same age who they could look up to, who are successful by the, their standards. What we think is successful is not what they think is successful. So a girl who is an influencer on a social media, who has the best reels, is probably their idea of success, right? A girl who is with her second boyfriend is probably their idea of success. So all those things which would not otherwise go into our minds is what they admire. So those are the people they listen to. So these are a few tricks. These are all counseling tricks, and still it's very tough with adolescents.
Well, can I just raise my question here?
You are mute, Dr.
Dhruvi, you're mute.
Okay. What I have seen for a long time, even I have type 1 as well as type 2, and also gestational. My idea is, if we explain to them, I have got a type 1 surviving till they are the age of 38, my last follow-up, when I left my practice. And he's doing it so well, but in between what he does, he just goes off. And that is the time when her parents, they just slap him and bring him back. And this has happened 4 or 5 times. And after that, he's doing very well. And now he understands type 1 as much as I know about it. The education, if we start in the beginning, in my long practice, whether it is a female coming with a gestational or without gestational diabetes, they are all just taking this issue. If we are educating them well, we have to spend time. That is main thing. If we are spending time with them, they understand and they connect with you. Correct. And for their hypoglycemia and hyperglycemia, they understand very well. And I always give them a chart. This is what happens if you don't listen This is what happens if you listen. So they
Thank you,
just, their point is education. If we do it, if they are taking from Google or something else, it's not the same thing.
Correct.
So my point of view is whatever you are saying, it's very correct. But my first thing is education.
Absolutely,
you,
ma'am.
ma'am.
There is no
I
type 1
have
diabetes
been
management.
treating diabetes for almost 50 years now. I have
Absolutely.
seen the difference. What is it, the local, our population, and what is the population abroad? Abroad, people are very, very well connected, and they have got diabetic clinics. They have got an educational system there. Whether it is he or she, I don't differentiate. She is the only one. They are usually obese.
Thank you, ma'am.
And it is very difficult for them to get the back to their proper size and proper insulin. That's what my idea is.
Thank you, Dr. Yadav. It was a wonderful input. I would just beg to differ that India is changing, our scenario is changing, and we are doing some really wonderful job. And I'll go back to Archana, ma'am, for that. Ma'am, in terms of the medical screening for an adolescent girl, for all the doctors who are listening to us today, ma'am, can you just point out or maybe enlist what are the comorbidities we have to screen for and what are the complications we have to screen for an adolescent girl with type 1 diabetes?
That's right. And that's why, our problem is this day in our country is happening. Ma'am will tell me that PCOD is becoming so much high.
Yes,
and
ma'am.
these girls are all working girls. And they are sitting
ma'am.
on the laptop all the time.
We will discuss this further and we will allow you to contribute more once Archana ma'am has contributed her answers.
Go ahead.
Thank
I
you,
just
ma'am.
wanted to point out about the juvenile diabetes.
Thank you so much.
So I think from if you're talking about investigations in a girl as she's growing, especially adolescent, first thing is, of course, till she attains her menarche, puberty, we are growth charts are absolutely essential in any clinic. You may be an adult doctor or a pediatrician, but growth charts are absolutely an essential because that is where the height and weight taken properly. That is absolutely important. In our clinic, at every visit, height, weight. Second thing, which is blood pressure, which is always to be recorded. Of course, a very simple but important thing that's recorded with the right size of the cuff, which often goes wrong. So that's very important to remember because for all the reasons. Then another thing is checking for the sites of lipotrophy. So, I mean, I know it's not part of an investigation, but I take it as part of one's, one short thing like height, weight, BP, and checking for the insulin sites for lipotrophy. Having said that, after that, all the guidelines wise, if we go, other than blood sugar level monitoring, which can be SMBG, CGMS, HbA1c is an important tool. Again, it's very important to explain to the children and the family that by itself, HbA1c is not a standalone gift to tell us that they're good, because many people get very happy if they are not being monitoring and they come with a 6 HbA1c, think that everything is fine. So that's not okay. It only has meaning when you have it along with the blood sugar reading. So that context has to be explained to them that it is hand in hand. And then there could be an annual screening. What we do is, of course, we screen for thyroid and for celiac disease. And these are the initial stages. Of course, a lot of talk. That can be a huge discussion about the antibodies and the C-peptide and all that. So I'm not even going there. I'm talking about the clinical screening needing for the care for the child. Other than these two, which essentially should be done anyhow, because even in also setting, we have to raise funds and do it. Other than that, then annual screening. You want to do the fundus, you want to screen for renal complications, and depending on the duration of diabetes, you would need not do it for the first 5 years in type 1, the way you would want to do it in type 2, but otherwise do it for the first time in at least first 5 years, and then annually if possible. I do it every year, raise funds to do it. We don't, minimum is set to be alternate year, but I do it every year and then as per the guidelines. So that is what we do. We also do many other things. I mean, there's a whole list which can available on the SPAD guidelines or our Indian guidelines as well. But at least this much emphatically needs to be used.
Thank you, ma'am. It is really exhausting sometimes for the people with type 1 diabetes also to go through all of this annually. We have Banshi sir back over here. Thank you, sir, for joining in spite of such busy schedules, and thank you for being the he to our He for She campaign. Sir, if you can enlighten our audience again about the pre-conception care. Archana ma'am was just talking about the list of screening
The
tests that we need to do.
pre-conception care is something which is very, very important, and we have to discuss in detail. And I just want to give an example that one of a very highly placed IIM girl, she had come to me, and I am sure those Dhruvi, you might be knowing her. And when I asked her for pregnancy, she told that, you don't know I am type 1, how I can be pregnant. And then I counseled her, we put her on pump, and she delivered a baby, and she's doing absolutely fine. So, this is such a big misconception that people feel that they can't become pregnant. So, preconception care is very important, but before that, more important is the counseling. They should feel that, yes, they can become pregnant. And now, Archana, the other girl who is on pump, she was not ready for baby, and now she is with IVF treatment. So now, Dhruvi, can I leave now?
Yes, sir. Thank you so much for joining, and
Bye.
thank you for being a part of our campaign. Thank you, sir.
Oh, bye-bye.
Thank you.
Thank you, sir. Bye.
So I would add, I'll take on from there for preconceptional counseling. Definitely it's important, but I think it has to start very early. And I would even go earlier than preconception is sexual health. I think if that was not something you were going to ask, then I'm just adding it here, that it's very important to talk to young girls and adolescents about sexual health. Contrary to what we may believe, girls are very sexually active. Right. And I was extremely surprised because I do adolescent group therapies, and I call in, Kishori care groups together and talk to girls. And when we do them in closed doors and small groups, what opens up doesn't let me sleep at night, because ultimately I think like a mother along with, think like it. So we must talk to them about sexual health, about protection, about safe sex, all those things which are talked about, which used to be so-called Western concept, has to be talked about to these girls much more. See, anyway, a girl should be talked about it, but with type 1 diabetes, it becomes even more important because it has a direct implication on their health. And then comes the preconceptional counseling. And this is a time I think it works, because anyone who wants to have a baby, any girl, I have yet to see, I'm a grandmother of 180 babies today. Okay, so I have 180 grandchildren from type 1 kids. I mean, those who came to me as kids and now they are mothers, but none of them had a HbA1c out of place in their preconception to delivery time. That is the highest motivating factor. Once they understand that what it takes, once they understand that for the health of the baby, every mother wants a healthy baby. That is a tool we should use. That is a good time to tell them all the bahanas that you made earlier for not being able to do it. Now they find ways of checking, of dose adjustment, and that becomes perfect. So definitely all the investigations, a good OBGYN who understands that this needs special care, ultrasounds by an expert, not just routine ultrasounds which are done. So all that network should be there between the OBGYN and the treating, but it works. It's the easier part.
I have another very hatke question, and I don't know how doctors generally need to answer it to be politically correct. How about tattoos with type 1 diabetes? How about smoking and drinking with type 1 diabetes? And how do we educate these young adults? They are no more adolescents.
So look at my tattoos. And the moment the girls come in, they tell their parents, "Ma'am ko bhi tattoo hai, hame chahiye." And why are you not letting it happen? And definitely with good control in a good, safe place, they are possible. I mean, that
So
doesn't
we can say that
encourage it.
they can get tattoos.
Absolutely, absolutely. If you can have babies, if you can conceive, you can do surgeries, you can also get a tattoo. Of course, the same safety that would go for everywhere else. Blood sugar has to be normal, all the safe care, the needle use, all those things have to be done. Many people would say, why say yes? I mean, why not just say no? But to understand that age, even not denying them a tattoo can trigger something very big. If that entire 3 friends have it and I don't, that it still can be a trigger to something very big. So one can explain pros and cons, but it can be done. Definitely can be done.
And how about the addictions? How do we steer them away from the addictions?
So what we do is first we talk about tobacco, which we say is an absolute no-no. Again, I said we don't give a social context to it. We give a medical context to it. So we don't say because you think drinking is bad, smoking is bad, isliye bachcho mat karo, because that nobody wants to listen to. But we do talk about how what tobacco or nicotine does to your blood vessel. So we talk to young boys about how it can help it can deter their sexual function when, because that is important. See, you have to give them motivation with what is important to them. Right. So they are not bothered about cancer because they think malignancy to kisi ko bhi ho sakti hai. But if it's going to be causing impotence, then boys don't want to do it. If it's going to be causing some other problem, the girls. So giving the right reason for not doing it and explaining science. I draw a blood vessel. I say this, look, this is where nicotine is acting. See how it's choking up. This is the pathway. And most people understand that. Right. So tobacco is easier to explain because it's so direct. When it comes to alcohol, it is tougher because everyone wants to experiment. And then one has to sort of talk to them about what is safe and how trying can lead to ongoing and what can happen, hypoglycemias, etc., etc. But their 100% results are difficult because ultimately peer group hai, thoda social drinking hai. Then if at all they show inclination, then it's important to tell them how to manage their diabetes if they are having alcohol. So what is safe and how to safely drink. That is important.
Thank you. Thank you, ma'am. When we were discussing questions as to what to ask you and sir, Dr. Kaumudi had this very interesting thing. How is the diabetic ketoacidosis that may occur during pregnancy? How is that going to affect the fetus in any way? Does it or does it not? And how does it?
It does. I think all the studies have shown that for the mother it is harmful, but for the baby it is extremely harmful because the baby does not tolerate acidosis, the fetus. So it often leads to IUD or early termination has to be planned. And that can be quite risky for the mother and child. So I have not clinically faced it, thank God. None of our girls landed in DK, but definitely it is high risk for the baby. Mother, because the priority to save at that moment would be entirely the mother. And fetal loss is very high in DK.
So thank you, ma'am. The other side of the story is the medical termination of pregnancy. With the type 1 girls who might have had accidental conception, how safe it is and how do we, medically counsel or take care of this situation?
This is very difficult, Purvi, very, very difficult because legally I could not find, this has happened with us and legally there is no way we can tell any woman type 1, type 2 GDM for any reason to terminate a pregnancy because of diabetes. We could not find any such rules anywhere. Everything is about clinical judgment of the treating clinician. And that becomes very difficult to, because there are so many emotions, family and all involved. So on a practical anecdotal note, experience note, what I can say is if I see a girl has been uncontrolled throughout, it's not just at that moment, but has been uncontrolled and it is definitely a high risk. I like to tell the girl herself that why don't you think about that? Because telling a husband and family becomes very difficult at the first go because initially the girl cannot say much in their pressure, in their presence. So if we feel seriously that it's going to harm the baby, because having a child without the best possible outcomes can be a lifelong burden. So definitely, and if detected early enough. So people do listen. We have had a few cases where we were able to convince them and later on they planned, achieved a HbA1c of 6.5, then conceived and then had a baby. But it's tough.
We have Vinod sir making a comment during the onset of puberty. The parents who once managed, yes, he's made a comment on the carbs and he's also got a question on teplizumab. I think, ma'am, we'll take it in the end once we've completed with the actual questions. My next question to you, ma'am, is about the post-menopausal and the perimenopausal females with type 1 diabetes. We have extensively seen now that people with type 1 diabetes are living longer and longer with better technology, better care, and better quality of life, and some even without complications. So, if these women are into their postmenopausal time period or even perimenopausal time period, what could be some extra care that as healthcare professionals we should be taking care of in these females with type 1 diabetes?
I think, Dhruvi, this would be a very theoretical answer from me because I currently do not have women, at that stage of menopause, perimenopause. My oldest is still 38 with 30 years of
Yeah, like Dr. Yadav just said, her patient was 38 years old.
I know. So I was also otherwise anyway, just for another reason, looking up. So there's not much information on what could be different, right? So
Is it because we don't have so many females
I
living to
think
that
so.
age? Yeah.
Because last time for some other time I was looking up all the data and everything. So I could not find much which was specific to type 1 diabetes and what could be done. But all the care that we otherwise take, let us assume the same kind of metabolic care for a perimenopausal age.
Yeah, that's true.
Anything specific you can think of, we can share because I cannot think.
Maybe bone health issues or some cancer related education that we need to give this women. I don't know, maybe we
But
could do more.
specific to type 1, I could not find anything which is more at risk for some reason. Like more studies could be.
So that brings us to the mental health issues now in
Okay.
type 1 females.
Okay.
Even a adolescent girl or even a small child with type 1 diabetes could be affected with depression and anxiety or making so many decisions, or having the family members always focusing on them कि मेरा बच्चा type 1 है, and you have to, poor guy has to take insulin all through the day, a poor girl, she cannot eat this and cannot do that. Does that affect that child in any sense
It
in
affects
the
immensely.
adolescent and the pre-pubertal era?
So it immensely affects the mental health of a person. However, there is a whole range of what we call mental health. And often we loosely use the term by saying that person is depressed. So I
Yeah.
think we should be very careful when we use words like depression, because that is a clinical entity which should require an expert treatment, right? Because that is a diagnosis by itself. So
Yes.
there's a whole spectrum. And usually what we could call is some distress, which is related to the disorder. For diabetes would cause distress. So there are good diabetes distress scales which can be used to analyze that if needed. But otherwise, it is natural to find that distress would be there. There would be anxiety because you're always trying to cope with something constantly. There's no liberty to be spontaneous, right? So you're always having a targeted thing, and that is why there is anxiety. And then there is definitely some people get stuck in the that grief has a whole staging, right? From all the way from denial to, so people get stuck in various stages of that spectrum. Finally comes acceptance, but sometimes they just stay in denial for a very long time. You will find people after 5 years of diabetes diagnosis also yet in denial that they are actually living with type 1 diabetes, and hence 100% committing to the care. So emotional and mental, psychosocial, emotional, mental health is a spectrum. And to label it as any one thing, and especially the word depression, should be taken very, very carefully, seriously, clinically before labeling a person as depression. Right? And it exists. We have done lots of studies and we are also looking at our children, and it's quite a lot. In fact, you'll be surprised to know that almost 1/3 of the population, the AYA population, the adolescent and young adults across the world, without any disease, disorder, or chronic problem, also 1/3, almost 1/3
Number.
are in this spectrum, right? So it is a problem of that age, added to then a distress which comes from diabetes. So put together, the level goes a notch higher. And add to that, if like in a place where I live with my girls, there is a huge psychosocial burden from their family, especially for girls. Here, because we are talking about gender specifically, girls have extreme stress because their home environment is not conducive to what they want to do in life. Right? So that contributes greatly as an add-on, and hence more girls come on to the depression side of it. if you see the genders as compared to the boys. But otherwise, clinically, they would be similar.
And socially also, are the adult women more burdened with type 1 diabetes, taking care of themselves, taking care of the family members? Does that happen only with the females more in comparison to males, or the males have their own set of problems?
They have their own set of problems. Men are having as many challenges because they have to, for example, women still are wired to seek support. Men have to pretend they're, like they absolutely do not need any. I mean, that's how the social wiring is. And women still, at least socially, have a choice of earning a little less. I mean, that's true for even non-diabetes, but men are nothing if they're not earning, I mean, from a social name. So the way they rebel, the kind of pressure they are in their job circuits, if they're taking insulin, their self-esteem. So actually, boys, I find mine are even more challenged. Women are challenged in a social scenario because they themselves do not take care of themselves, unfortunately. I mean, they would prioritize their family first. I mean, my girls who have great in-laws would still not eat on time because pehle in-laws ko khilana hai. I mean, they're just trying to be good, wired from childhood. Ki mom-in-law has not eaten. How can I eat? Arey, Baba, you have type 1 diabetes. She has said you have it. So there's no problem from their end, but they don't prioritize themselves. Women undermine themselves, even in a good scenario. So that is something we have to talk
Now
about.
that is
always.
changing.
That is changing, but it's still happening. Between
It
a man
happens
and a
most
woman,
of the time. It happens, but it is changing.
definitely changing.
Sure.
I mean, way back it was horrible. Now it is definitely better, but in rural areas it still exists the same way.
So we have some amazing comments from Vinod sir. Vinod sir is in the States right now. Very kind of him to be joining us. Sir, if you would unmute yourself and put on your camera and please bring out your comments to our audiences, please.
I can see the questions in case there is a.
So we cannot hear you. So has written some excellent comments, as in he said that it is during the puberty that the parents sometimes realize that the carb ratio, which was 1:30, suddenly becomes 1:15.
Oh, yes.
And it is the pubertal time that hits these kids, both males and females, in the same
And
manner.
that has to be reevaluated very often.
Yeah.
The carb ratio has to be reevaluated frequently and during pubertal spurts, so very frequently. Absolutely. That is an important factor.
So it's also written that there are some other challenging factors, such as estrogen, that is accompanying the stress factor, the emotional and the social aspects. And these are the teens that have a lot on their mind, and their preoccupation can lead to non-adherence to the insulin injections, to the sugar checkings, and other necessary supplies.
I am so happy to read this because I think because Dr. Vinod is based in US, he understands that teens as individuals. These are things he's talking about teenager girls as individuals, which is something our families just don't want to understand. I mean, when I talk to my parents, I mean, my parents as in the parents of the children with diabetes, the parents do not understand that this child has so much on her mind. There's so many things that a person at that age, 15, is worried about. They think they have a home, they have food, they have good clothes to wear, you have going to a good school. What else do you want? How can you be, what is your stress? You have the best of insulin. So it's very difficult for parents. So in fact, I would say the biggest challenge is parenting. I mean, for parents to be parenting and for us to be talking to their parents. So for me, the biggest challenge in type 1 diabetes management in girls is their parents.
Thank you.
I don't know. One thing I will say, the challenge
Dr.
must be there, but I have known two things. They are very strict, even the teenager girl. One is HPV immunization immediately. Now I am seeing even the rural people are coming, but you tell them that she has to take insulin, they will think 100 times. कोई गोली नहीं है, there is no tablet, nothing like this. They will take 100 times. But if you tell them that HPV आपको immunization कराना चाहिए once the puberty starts, everybody goes immediately. So we have to, sometimes I think we have to find out something that they take it up easily. Parents also don't like that their child has got a diabetes. I'm not diabetic. Mother is not diabetic. How can she be diabetic? That is their question.
Yeah.
So we have to devise something, if really want to devise, to make them motivate to give insulin to the child and how it is. Parents have to be educated that way. That's very important.
Thank you, Dr. Yadav. Can you also introduce yourselves? You've made some really important comments to our audience today, and it'll be very nice for all of us to know more about you.
Because Dr. Archana has given a full, very good review of everything and how we feel difficulty in the time when these patients, especially type 1 or gestational diabetes also come. They take it very hard to them. Dr. Archana has given a wonderful summarize everything for us also. It may not be for patient, but it is good thing it is on YouTube. At least half of my patient, when they come to me, I'll say, see this seminar. You will understand, especially for the type 1 diabetes.
Thank you, ma'am. Dr.
Very
Archana
nice,
has been
Dr.
doing a lot
Archana. You
of.
have given a wonderful review of everything.
Thank you, ma'am. Udan is the name you want to search on the internet for type 1 diabetes advocacy. It is an NGO, ma'am. And she's doing a wonderful job with the type 1 girls and boys both. So with that, ma'am, we have exhausted with our questions in with regards to the female-centric care for type 1 diabetes. Would you want to add anything extra, ma'am?
Yes, I think I would just like to just few steps since we are at talking about type 1 diabetes. I feel a very important part is the first consultation. How can you make a difference in a life of a child with type 1 diabetes and their family and their caregivers is the first consultation. Hence, doctor education is extremely important. The language you speak to the parents and the child is very important. If the first consultation is of pity and horror and a scare kind of a thing that if you don't control your diabetes, your child is going to land up with kidney disease or blindness, then the whole life is going to be in fear. Later on, no matter what you do, it's going to be very difficult to bring them back to a positive acceptance of their diabetes. So I feel the first consultation, so every doctor should take care of a person with type 1 diabetes if they are capable of. And I'm sorry if I'm putting it very, very vocally, but if we are not, because for example, I know what I don't know. And if I can't do this, then it's best to send to a place where somebody can care, because the first steps, the first few steps, for example, not putting a child on a premix insulin, which is still happening. I mean, it sounds like, oh my God, why would anyone do that? But it still happens. So starting basal bolus, talking about monitoring and telling them how life is going to be great living with type 1 diabetes is the first step. And then connecting this family to wherever a structured education is available. If you do not have the capacity to do it, which is absolutely fine, then find the nearest geo market in your map, that where is the nearest center, and send the child where they can be taken care of. Let no child be deprived of not just insulin and glucometers and strips, but also structured care and peer group support so that they develop not just physically, but also emotionally and psychosocially. And one more thing, the technology that has come up is amazing. And we can use technology not just in people who can afford it, but we can find ways to do a lot of jugaad and use it in low resource settings because they benefit it the most. Imagine where there's illiteracy, and if they can have a CGMS and they can have something where I can see their graph and help them set their doses, they need it most. So if we can find a way of funding, it is the lowest socioeconomic strata people who benefit the most from their best of technology. So let's not write it off only for the privileged. So these are two things which would make a big difference.
Thank you. Thank you so much, ma'am. You've done a fantastic job in teaching all of us as to how these girls are a little bit different. They need more care with type 1 diabetes. I am going to the he of our He for She campaign again. And we have Dr. Vipul Chawda, who's supporting us as the he component of our campaign today.
Very
in
important.
in the physical, mental, social, financial structure and strata. So, Vipul sir, tell us your experience with type 1 diabetes and the female male gender bias that you must have seen or experienced.
Yeah, first of all, thank you so much, Dr. Dhruvi, for this wonderful program. And for all the audience, I would like to introduce Dr. Archana Sarda ma'am, who is doing exceptional work. She is covering 360-degree aspect of management of type 1 diabetes. For most of the clinician, most of the doctors, type 1 diabetes management is just insulin. But I would say insulin is only 30 degree of that 360 degree. You have to cover so many aspects. You have to go into the not only brain of the patient, but also you have to enter into the family's life, their social status, their economical status, their cultural status, their traditional everything you have to understand, and according to that you have to advise anything. And madam is doing wonderful job, and she conducted one of its own kind in world's first type 1 diabetic meeting in Aurangabad, or from Chhatrapati Sambhaji Nagar, I would say. And that was a superb experience for all the doctors who are managing type 1 diabetes. So what she had said in last 40-50 minutes must be on social media, Dr. Dhruvi, and many people should learn many things from that talk. I would just like to add one comment, and I would seek advice from the madam that in my initial year of practice, I saw one patient, a lady who actually brought death to my hospital. She was not alive when I examined her, but then what history I took from the relatives, they said that she was type 1 diabetic. She concealed the history that she was type diabetic, and then marriage was done, and she didn't take her insulin for 3 to 4 days. She had an episode of decay, and in the village they consider there is something supernatural, and she is not feeling well, she is hysterical. For 1 or 2 days they took treatment from multiple doctors, but they didn't find that she was type 1 diabetic because it's a rural area India and there was no facility available. And we lost the life of a girl. Still in 2024, in our hospital, even in Ahmedabad, we find some type 1 diabetic, and at the age of marriage, and they are saying कि सर हम उनसे थोड़ा छुपा लेंगे कि उसको डायबिटीज है, फिर 1-2 दिन में धीरे धीरे रिवील कर देंगे. So this is a very tricky situation के you cannot be harsh to the family कि ऐसा तो नहीं करना है, आपको सब बताना है, but we have to put this message in a gentle way. So ma'am, with your experience, can you give us some idea how we should talk to such patients and families?
It's a very important point, and I wish there was a gentle way. So I think there is no gentle way, because for some truths are harsh, but very important, and they are non-negotiable. So like when people ask, ki, one day will this insulin stop? Can later on we go on? That is a time, there's no time for gentleness. There is absolute non-negotiable answer. Yes, you have to take insulin maybe for the rest of your life till there is a cure. Of course, you merge it with like a good life with diabetes, etc. Similarly, for marriage, I have found no gentle way of telling them. I insist and absolutely insist that it has to be told. As a result, first 10, 15 suitors will say no. And we explain to the parents, if in an arranged marriage, they say no because your daughter takes insulin, then what will happen after marriage? Those are the girls who will land up in hospitalization again and again. They will send the girl back after 4 months or 5 months or 6 months, whenever they discover it. So it's okay if the marriage is delayed. Wait till you find person who is willing to accept you with your type 1 diabetes. And thankfully, when we are firm, because I tried the softer way and nothing worked. So we are absolutely, absolutely firm about that. And we tell our girls that if they don't tell, when the boy comes to see you, you whisper in his ear, I have type 1 diabetes and I take insulin. Because they may not put it on the biodata, but when they come and see, the girls tell them. And these girls understand. And that is the only way. I don't think there's any negotiation there.
Thank you so much, ma'am. And we find the same thing, that it is very clear message from a doctor that it should not be hide, or it should not be concealed. So with respect to the time, I would say thank you so much, Dr. Artna ma'am, from wonderful elaboration of every aspect of management of type 1 diabetic care and in perspective of female care. Thank you so much, Dr. Bansi sir, who is always our teacher, mentor, guide, and guru for everything beyond diabetes also. Thank you, Dr. Dhruvi, for starting such an initiative where we have to make a precise care for the female. See, in our society, we always talk about equality and equity, but I would say, and we often discuss with Dr. Dhruvi in our discussion, that our society is male bias. If something new step is taken by male, there is more chance of acceptance. And if the normal traditional thing if female does starts first, then she might be asked questions. So I always say that males are a first gear of the car. They should start the things, and the rest of the thing will be taken care by the females. They can run the show throughout. So all the doctors who are male who are listening to this, that you have to put some extra efforts, and then rest of the thing will be taken care by all other female colleagues, doctors, and counterparts. With that, thank you so much for listening. Thank you so much, all the doctors, for joining. And let's do something every day to have some better thing in the life of a patient with type 1 diabetes, whether male or female. Thank you. Over to you, Dr. Dhruvi.
Thank you so much. So allow me to end on the note that we are from Rudraksh Institute of Medical Sciences. I'm Dr. Dhruvi Hasnani and he was Dr. Vipul Chawda. I have the resonance of Dr. Archana Sarda ma'am when I visited her place. And she told me, Dhruvi, not all battles are meant to be fought. And it was the same thing when I started working with Dr. Vipul. He's like, use me. You don't always have to fight. You use me to make your work done. The important thing is that the work gets done.
Yes.
So I've had amazing people always with me for, making some changes, be it on a small level or be it on a large level. Thank you so much for being a part of this. I have amazing team of girls with me, Dr. Kaumudi, Dr. Nimi, Dr. Smruti, Dr. Tarjani, Dr. Dhara, all of them who are here. All of them had this fervor, ma'am, that, we want to do something with regards to everybody working for the women, and not just in terms of physical health, in terms of the whole sphere. So we just started with this small step. So thank you all the girls who are present here, and thanks to all the he's who have supported me throughout. Dr. Vipul, Dr. Banshi sir, Dr. Vinod sir who's present here, Dr. Gedia sir who's present here, and Dr. Supratik who just logged out before I could say a thank you. So thank you, and thank you to the team of RX for making this happen. Thank you, Archana ma'am. Thank you, Dr. Yadav, for your wonderful inputs.
Thank
Let's
you
keep
so
continuing
much.
this.
More power to everyone here. Wonderful.
Thank you.
Enjoy
Thank
being
you,
here.
ma'am.
Thank you.
Thank you so much.
Thank you,
Thank
ma'am.
you, ma'am.
Bye-bye.
Bye. Bye, ma'am. We can